today. So I'm Gretchen Roe. I'm one of the faculty at Cornwall Health, and I will be talking about interventional procedures in palliative medicine. A lot of these procedures we'll be talking about are related to pain. So I hope that you come away with this with some new pearls and tips that you can apply right away to your practice. Let's see if I can adjust and get my screen going. All right, I have no disclosures. So some objectives for today. We're going to talk about why interventional procedures should be considered in palliative medicine, describe indications and risk benefits for common interventional procedures. There's a lot we won't talk about, but we'll talk about the more common procedures that we should be aware of. We'll talk about which procedures are preferred for different types of pain, whether it's somatic, visceral, neuropathic pains. And we'll talk about when neuraxial blocks and infusions, that's your epidural intrathecal pumps, that when those could be considered as part of the palliative medicine toolbox. So a little flashback to, we'll talk a little bit about general pain back to July when we had our initial pain lectures. So cancer pain has a pretty high prevalence, especially in it has high prevalence in cancer, about 30%, but as high as 85% in more advanced disease. And we know that pain is moderate to severe in about 50% of patients with cancer, and probably the ones we see, it seems like more than that, because we're seeing the ones that are referred because they have a lot of pain. So it seems like that's a low number. But in general, that's what the research shows. So, and the pain can be related to cancer itself, metastases, the treatment of the cancer, or other comorbid conditions. They have their chronic back pain on top of their cancer-related pain. So about 10 to 20% of patients have unrelieved pain despite our best pharmacologic and non-pharmacologic therapies. We're doing all the best opiate conversions and rotations, and it's just not doing the job. Or they're having side effects that are limiting their ability to function. This percentage in this group of patients, this is what we're going to talk about today, when all those standard things are not working or not tolerated. And a lot of things that I'm talking about too could be its own lecture in itself. So this is a broader overview. And there's always opportunities to dive deeper into each of those different things that I'll discuss today. So we're familiar from our prior pain lectures about, there's a World Health Organization recommended step ladder as a guideline for treatment for pain, starting with Tylenol and then escalating to opioids, where opioids are known to be the first line approach for moderate to severe cancer-related pain. But we also know there's significant risks to opioids that can impact function, quality of life. And so we think, what other options are there out there when those are not effective or, again, not tolerated? So when we should consider interventional therapies, or why we should, as pain relief, decrease systemic opioid requirements and therefore side effects. And those side effects that we know well, the cognitive impairment, nausea, vomiting, constipation, respiratory depression. We can have improved function. That's a huge one. And improved quality of life, therefore. And a side benefit being reduced medical costs, because being on a lot of expensive medications and hospital admissions, ED visits, that price adds up. So that's the why we should be aware of the options to offer our patients. And going back to that World Health Organization step ladder, we shouldn't wait. Sometimes if you look up there's a lot of different ladder variations, have like interventional procedures is now added as like a fourth or a higher level step. That's sometimes the case, but sometimes it's okay to offer them early and when you're using those in that opioid phase, because you don't have to escalate to high dose opioids to consider interventional pain procedures. And there's times when certain procedures are indicated early as opposed to last resort. And we'll sort of talk about which ones are those early and often considerations versus those more last resort. So I won't go into too much detail because this is a lot of review here is the different types of pain. Just remembering when we are looking at these procedures, the nociceptive, more somatic visceral pain types and what causes them versus the neuropathic pain. Because there's different procedures that impact different types of pain. And we know neuropathic pain itself is about 40% of cancer pain syndromes. And many times, as we know, for our cancer pain patients, it's a mix of different types of pain. They could have it all different types of pain that we're addressing. So to begin, I will start talking about different nerve blocks. And there's different categories I'll break it down into. We'll start with the sympathetic blocks, then go to peripheral nerve blocks, followed by neuraxial blocks and infusions, which are your epidural and intrathecal infusions. And something new this year's lecture, I wanted to add, because this has always been a question of mine too, is, there's a lot of great procedures. These sound fancy and fun, but what is the evidence? How effective are they? Because I'm sending our patients, referring them, and oftentimes procedures are like, yes, we'll try it, but I want to do the right thing by the patient. And what is the evidence behind different procedures if we have it? So not every procedure I talk about, I'll have the grade of evidence, but many I do have, and the source that I have for what I will be mentioning today is listed on the bottom of this slide here. And this comes from best practices and guidelines for interventional management of cancer-associated pain from the Journal of Pain Research, 2021. So you can go back later. I won't go through the details of this evidence level slide, but if you're not familiar with these levels of evidence level 1 through 3, and then followed by the grading of degree of recommendation, the A through I, which is insufficient evidence. You can look back at this later. So sympathetic blocks, big thing, highlight, star on this slide. What does sympathetic blocks help with? What kind of pain? Visceral pain. Key point. So get my bearings here. Okay, so, and I'm gonna go back to that main slide for a second. So visceral pain, so that's where there's afferent input traveling along the autonomic nerve, so that there's a lot of automatic nerves are mixed with the visceral pain pathways. So when we do sympathetic blocks, it interrupts both those afferent pain pathways, but also concurrent blockade of the sympathetic nerve system, because they're just together. And so when you block those areas, you can get unopposed parasympathetic activity. So that's why you can have side effects of diarrhea or orthostatic hypotension that can be transient. So that's just something to be aware of with those. So sympathetic blocks typically come in a couple stages. They're guided by CT, MRI, less likely MRI, more CT and fluoroscopy, I'd say, depending on the location. And it's usually that two-step process, the first being the test dose. I tell the patients, the prognostic therapeutic nerve block. Does this work? I often refer and tell them it's like getting a dental block. It's going to last for a certain amount of time and extended, sometimes some hours, but it's going to wear off. And you have to tell them that in advance, because else you'll see in the next day and they're like, I still have the same pain. And they'll say it didn't work. So just set them up for an understanding it's temporary, a test dose. And that's typically when you get an anesthetic like bupivacaine plus a steroid, Decadron is often added. So that the local anesthetic will last for a period of hours. The steroid sometimes takes 2 to 3 days to kick in. So that's where that can have, it can potentiate the effect of the local anesthetic and that's why if you have someone have a block that lasts days, weeks, it's because that steroid it really helped. So yeah, some people, the pain comes right back within hours. Some people, but that first 6 hours was great. And some people, it can last for a while and they don't need to have an ablation. So typically our interventional team that works with our hospital system will call a patient in 24 to 40 hours to check back and ask how those initial hours went. What they're looking for is an improvement of 50% or more of pain control. And if that's the case, they could be a candidate potentially for going on to an ablation. The ablation, the therapeutic also known as the therapeutic neurolysis, is more of the permanent block. It's not necessarily permanent. Nerves regrow, pain could come back, and it may need to be repeated in the future. And the patients that I've sent for neurolysis, it tends to last months, years. And so I haven't had to do repeats myself. If they did work, they tend to stick, but that's my own experience. So the alcohol, a very, very concentrated alcohol, is used for the therapeutic neurolysis. And sometimes what can be frustrating is if a patient they respond to the block, but then they go and get the ablation and it doesn't work. And I always ask, why does that happen? And it's because it's really hard to get that alcohol right in the right spot, because they have to use just not too much, just the right amount, and they don't want it to leak around to the other structures because it can be destructive. So they just may not get it in the right spot. So that can be challenging. So the risks of this procedure, neuritis, sort of phantom deafferentation, pain, or regeneration. Again, I haven't seen that happen as much, so I think it's a low in general likelihood that could happen. But the benefits can be great, like overall decreased opioid use, side effects, improved quality of life, the things we've talked about. So I like this figure because it shows where we're going to be talking about a few of these, the more common ones I'm going to focus on today. So the celiac plexus, superior hypogastric plexus, and ganglion impart. You can sort of see where they are along that sympathetic chain. So let's start with the most common that you're probably familiar with is the celiac plexus block. So this block is used for upper abdominal malignancies that are associated with visceral pain. Again, that's that visceral pain, the one that can be really hard to treat sometimes. So that's, and it's located around T12L1, and it innervates a lot of the abdominal viscera. We often hear it for pancreatic cancer and think that's the only area it helps. Well, this is the whole, this is all the different organs that can be, if there's pain in these areas or stretching, it can be improved with this block. So I really say that for this block, it innervates from the distal third of the esophagus all the way to the transverse colon. So it can be accessed intraoperatively. Sometimes they're doing it when they're in there doing a Whipple or other surgery. It can be used fluoroscopy CT guided with an interventional team. And GI docs actually perform this procedure, often a block and ablation at the same time with ultrasound guidance when they're doing an upper endoscopy. So oftentimes I sort of look, if I feel like a patient could benefit from a celiac plexus block, I sort of say if they're involved with GI, oftentimes they can be, if they're already going in, I ask, can you, while you're in there, do the celiac plexus block? And it tends to go smoothly, and it's just like a one-step process for patients. And so it has a higher success rate compared to other sympathetic blocks. Evidence level is 1A. Very good evidence, very effective. Think of this early. Do not wait till you're on high-dose opioids. If I have elderly patients or patients who don't want opioids, I refer them early for celiac plexus blocks. And sometimes you need to follow up to make sure they get the ablation, because sometimes that can fall off the radar. And please, I want this to be interactive. I know it's hard with a big group, but if you have questions, please put it in the chat. I'll have some of my people here monitor the chat. I have it open too, but I can get distracted from that. So please share a question you have along the way as we go through. I like to have some photos because you're like, where and how are they doing these procedures? So you can see if I can show you. Here's the celiac plexus. Look at how close it is to the aorta. A little scary. Sort of glad I'm not doing these procedures. So right next to Big Red and right next to the thoracic spine here. So you can see why the posterior approach can be pretty nice, because it's a lot less you have to go through with these little needles than going through the anterior approach. And so that, then there's this was an anterior approach. You can see the image of the needle coming through, and then they have to inject contrast to make sure they're not in a vessel, they're in the right spot. So any images I'm showing are from, a lot of them are from here, our interventional team, and then showing the procedure. I mentioned before that diarrhea can be probably the most common side effect. It's transient. Orthostatic hypotension can happen, transient as well, of that unopposed parasympathetic response. There's the different, more rare side effects, pneumothorax, increased pain, the alcohol intoxication, if it sort of extravasates out. Contraindications are coagulopathies and bowel obstruction. So again, remember these for this procedure for patients with malignancies of the upper abdomen, distal esophagus to mid-transverse colon and all around that area. All right, so what if that celiac plexus didn't work? You're like, man, I thought that would be effective. Why didn't it work? So if let's just say pancreatic tumor is just embedded all around that the celiac plexus area, they just cannot get to it effectively. And sometimes the procedural knows that, but they may not say that either. I found like it just didn't work. I said, well, how about a splanchnic nerve block? So the splanchnic nerves here, so I'm going to show the celiac plexus is right here, if you can see my arrows, and then up here, little, I guess, more posterior and a little more out of the way, are the splanchnic nerves, but pretty close. So there is actually 1B evidence for considering splanchnic nerve block, especially for intractable abdominal cancer-related pain. And it works even more effective. There's a randomized controlled trial that showed that it can be even more effective than celiac plexus block for blockade for pancreatic body and tail cancer versus pancreatic head cancer. So definitely it could be a second step if that celiac plexus block didn't work. All right, we're moving down. We're in the L5S1 area where there's a superior hypogastric plexus. And so that innervates the descending colon, rectum, uterus, bladder, prostate, due to some just ways the blood flow, different things. It just doesn't help as much for ovarian pain. Similar types of risks that you can see here, or some puncture, injuries, all those things. So it has mixed results. I think for this one, it sometimes helps, sometimes doesn't. But when you have refractory pain, it's worth a try a lot of times. So used for that visceral pelvic pain, evidence is 2B, and I think what's difficult is getting that alcohol in the right spot for that. So that is the challenge. It does not, just remember, so it's for that visceral pain. So if someone's having a cancer that's just in the pelvis and growing, and they're having muscle involvement or neuropathic pain from root compression, this block would only help the visceral part of the pain and not those other aspects. So that's where sometimes people need a couple different types of blocks, or this block will partially cover their pain, and then they need opioids or other interventions for the other types of pain. So here's again some different images, shooting the contrast to make sure we're in the right spot. Something I'll mention later, because I'm adding a section today about some neurosurgical procedures that can be used. So I'll mention it later, but I'm mentioning it now because if you have more refractory pelvic pain related to cancer, there's something called a dorsal punctate midline myelotomy. So that's a neurosurgical procedure, and it will be on a later slide, but that in some case series has shown that it can be helpful for that intractable visceral pain when nothing else is working. Oftentimes, those are patients with a shorter prognosis, maybe a couple of years or less, but with these refractory pain syndromes. So we'll get back to that later. A little teaser for later in the lecture. All right, moving down. This is our last ganglion impar, or sorry, our last ganglion block of the sympathetic chain is the impar block. It's the end of so the sympathetic chain has two sides, and then it converges to a single structure at this point. So it's used to treat that visceral pain. And this in these areas, so distal rectum, gluteal, perineal, distal vaginal, scrotal vulva, those areas. So I think the superior hypergastric goes to like the transverse colon, descending colon, all the way to the orifices is what I say. And then once you're sort of near this is more that external pain, when it's more external, right at like the orifices, that these this block particularly can be effective. Similar to hypogastric block, it can have mixed results, maybe not as consistent as celiac plexus block, but it's helpful for those refractory pain situations, level 3B evidence for patients with intractable perineal cancer-related pain. And so something to consider. Sometimes it's used for radiation proctitis, cancer of the lower rectum, anus. So those are some indications. Just sort of an image of where you're seeing the block being performed. So you may ask, which this came up in my questions over the years, when do you do a pudendal block? Okay, this is a peripheral nerve block, so we're sort of just comparing the peripheral nerve block to our ganglion impar. So a pudendal block can be more effective if the pain is more superficial or interior in that pelvic region, perineal region. If it's more posterior, deeper, the impar block can be better. So a lot of times your interventionalists may know this and recommend one. So I'm not saying you have to be an expert and know exactly what procedure to recommend, but I do think it's helpful to have some ideas and be familiar, because sometimes it is you that's going to advocate for trying again, or maybe they need both. It's very common that patients with these complex lower abdominal pelvic pains need more than one block to get all aspects of their pain, or at least a lot of it, covered. All right, so let's talk a little bit about the last sort of sympathetic block I'll talk about is the lumbar sympathetic block. The lumbar sympathetic chain near the L2, L4 vertebral bodies give that innervation to the lower extremities. So sometimes blocks can be effective for invasive tumors around that area, phantom limb pain. Sometimes these peripheral vascular vasospastic kind of pain in the lower limb that can be tricky to treat. Groin testicular pain, lumbosacral neuropathy. So that's where those blocks can be effective. They usually do not do ablations because of by some time. Maybe the steroid can help it to, last longer than just hours. Just want to make you aware of this option. All right. Any questions on the sympathetic blocks before we move to peripheral nerve blocks? So looking at the chat, I don't see any questions yet, but let me know if you have any. All right, so peripheral nerve blocks. This is somatic. They can help with neuropathic pain as well, more localized pain. At our institution, we have an anesthesia pain service that can be helpful a lot of times for these peripheral nerve blocks. So these blocks we know that peripheral nerves can be impacted by compression or invasion of a tumor or metastatic lesion or degenerative disc disease, wounds, chest tubes, thoracotomies. A lot of things can lead to nerve pain here, peripheral nerve pain and somatic pain. So we can use these nerve blocks alone or in combination with other therapies. It's great when patients are trying to minimize their opioid use. These are procedures we use early and often when they're indicated. It could be a single injection block versus a continuous infusion as well. So we'll talk through some of these things. Let's see. Yep, and the risk can be neuritis, the deafferentation pain, and rarely do we ever do a peripheral nerve, like more of ablation like we do with those sympathetic ganglion nerves because of the risk of motor loss. But there may be those situations where someone already has loss of function, it's not coming back, where maybe it's worth it. So I'm going to share first my favorite one. I use this one quite often. I find a lot of my patients that come to clinic who have, they could have maybe lung or breast cancer with local extension, metastases to the chest wall or rib cage. Maybe they have multiple myeloma or like metastases all along their ribs and just severe pain. Rib fractures with more chronic, that's not, more chronic pain from that, chest wall trauma, or it could be for acute rib fracture pain. Post-mastectomy syndrome, post-thoracotomy syndrome, so common, chest wall wounds. So just all of those things, think about this early because it just works. It is highly effective. I don't have an evidence grade for it, but if I could give my Gretchen evidence, it's just super high and effective immediately. So ultrasound, so it's minimally invasive, ultrasound and fluoroscopy guided. It's right there. They don't have to go deep like those other blocks. Bupivacaine often used plus that steroid for that test dose. Same thing with this. It's a test dose. That test dose may work for a while. It may just work for, depending on how that steroid kicks in, or it could just be hours. If that's effective, then they can go on to intercostal ablations, and those can last weeks to months to, a long time. And sometimes they can be repeated, but I've had people over a year, still no pain, totally numb in that area. So they will have numbness. But if there was a story I have of a young woman with breast cancer, huge wound, just sort of eating away at the chest wall. Young kids, didn't want to show her pain around her kids, but just really was like crying, screaming when she had her dressing changes. So just traumatic. So she ended up having a 4-level, and these are her photos here, a 4-level intercostal block and then ablation. And they did a cryoablation. So that's the cooling. There's like heat types of ablation and cooling. This is a cooling where you see the ice balls forming, so they know that it's in the right spot. And she had immediate pain relief and had actually 3 weeks of pain relief just from the block alone. And then had just great results from the ablation and was able to tolerate dressing changes. So therefore, you don't need all the opioids. You could really go down on medications. So
Gretchen, I've got a question a minute, if that's all right.
Yes, please.
I love this idea of the nerve blocks. And this is something that our inpatient team talks about all the time is could we get a nerve block? And a lot of the conversation with anesthesia is, well, it's temporary, so we don't necessarily want to do it. But it sounds like you're then able to follow them up in the outpatient and carry on with some of the ablations in the next kind of the follow-up steps then?
Yes. Sorry, I was just trying to work my screen so I could see and part of my screen here. Yes. So if, let's say in your hospital, they do the block, but they don't do ablations for whatever reason. A lot of times if they're in the hospital long enough, we can get both done. But sometimes it's just availability of the interventional team. And it's like, okay, that's another 3 days and we don't need to be in the hospital for other than that.
To wait for that.
So yeah, so you can, let's just say, I know locally, our radiology team that works at a lot of our hospitals here, you can make a referral and then they will follow as an outpatient, and they can get that done really in a timely manner. They try to get things done within a week or two, in a good case scenario, in the best case scenario. So yes, it can be done the second step later as an outpatient.
Sounds good.
Yeah. But probably one of my most commonly used blocks of everything I'm saying in this lecture. All right, thank you for that. So that's an example of just a block ablation. There's continuous infusions. I don't see, these are used a lot, maybe on our trauma services, post-surgical. So you may or may not see them. And I do not get any financial incentives to show pictures of an ON-Q pump, but I just think it's a nice one to show an example of, because that's what they're commonly using. And this is just here, get that back to my notes. So this ON-Q pump delivers continuous flow of local anesthetic close to the nerves for that targeted pain relief. This expander bulb you see here turns yellow when the medication has all been released. It's empty at that time. It sort of expands and you see the yellow part. So it's pretty simple. It has like a controller, so you can control the rate, or the person, anesthesiologist or whoever's controlling it, not us, controls the rate when they put it in. It's so that medication's just infusing more, just right next to those nerves. So this will allow more than that 8 hour or whatever the bupivacaine will last time frame. It could last days. So yes, this is not a long-term solution, because if you consult anesthesia, they may be like, well, this is only short-term. You're like, well, yeah, well, having a week of minimal pain for my elderly patient who doesn't tolerate opioids is a huge win, and may buy us some time to, get over the post-operative hip pain after hip fracture, for example. So, so that targeted relief can stay in for about 5 to 7 days. That's the limitation. It is a short-term plan. Sometimes they could put a new catheter in, but I'd say generally it's like 7 days and we're done. Each bulb can last about 2 to 3 days, depending on how the flow rate. But there's times when certain services like orthopedics will have a nurse come into the home and change that bulb out. But that's been hard for me to try to coordinate that kind of thing. Patients can be discharged home with this pump, and it's pretty easy for them to get taught how to remove the pull it off. So common things that you may see it used for, or you could recommend that it's used for in the hospital setting, could be for rib fractures. Instead of just doing that little block of the ribs, it just infuses constantly. So it's rib trauma. Again, if you have cancerated rib pain, that's just temporary. So you probably want to go onto the blocks rather than this option. But just that post-operative thoracotomy pain, this could be very helpful. I recommend, well, actually, we'll get to this, for hip fractures, a certain block, and you can infuse as well in that location. So we'll get to that. But this is another one, erector spinae plain catheter. That's sort of, they sort of enter it near the back area, but it covers like a wide spread of the chest wall. So this can be used for after thoracic surgeries, breast surgeries, to just provide those 5 to 7 days of decreased or decreased pain, hopefully minimize opioid requirements during that time. And this is especially helpful if sometimes epidurals are used, if it's contraindicated. This could be another option. So your patients with hip fractures or pain around that area, the fascia iliaca compartment block, these can be done by ED physicians. I know we have some ED physicians on these lectures. So we're trained to do this procedure. So if you, let's say you have your palliative or hospice patient who comes into the hospital ED after a fall with a hip fracture, please ask for this block, because they do it by ultrasound. It can give them hours of good pain relief while we're figuring out what to do. Are we going to operate or not? If we're on hospice, it's like having that goals of care conversation. So definitely consider that. And then if they're in the hospital, or maybe not, maybe they're going to go home, consider that OnQ pump kind of apparatus to have a continuous infusion, at least for a little while. So between that and Tylenol, some of these elderly patients, that's all they need. The brachial plexus is a complex structure there, as you can see, all the different areas and what part it innervates. But just be aware that there's sometimes tumors that are up in that area and cause severe pain. I don't use these as often because the block is temporary and you can't really ablate that area without having motor loss. So a lot of times if I have someone with pain in that area, I entertain the idea, I talk to interventionalists, but they're sort of hesitant because of what's that long-term plan. But if you have something that's temporary, maybe it's a surgery in that area, then maybe doing a continuous catheter pain relief with a local anesthetic could be an option to give, again, that temporary pain control. Right, I'm going to move on to cancer-related pain in the bone. We see this a lot with our cancer pain patients. Very common for patients with metastatic disease. Radiation is often one of those first-line treatments, but we know that there can be a delay, like up to 3 to 4 weeks to even start seeing a benefit from radiation. So there are procedures that have a really good evidence to support their use, including balloon kyphoplasties, radiofrequency ablation that can be done even before radiation. And this doesn't always happen. So this is where you can be your advocate for your patient. If they're having severe pain, really get your interventionalists and the radiation oncologists talking, and their oncologists, include their oncologists as well, and say, I think this patient could benefit from maybe an ablation or kyphoplasty first, then followed by, or osteocool, is that cryoablation, followed by radiation. And why is that? So you get that, it is pretty immediate pain relief. Sometimes a lot of patients, when it's to the spine, within hours, they significant decrease in their pain. And then if you were to do radiation first and then consider this procedure, the spine, let's just say it's a spine lesion, makes that vertebral body more friable, porous. So when they inject cement, so they balloon up the area, get that height back up, enter the cement, that could be more likely to leak if that bone has been radiated. So there's a lot of reasons that more immediate pain relief, probably safer overall, to consider this evidence 1A procedure early rather than later with refractory pain. So, and also having that cement, I think that's a key factor in any, when do you put cement in something? I used to think it'd be great for everything after I saw such great results for spine lesions. Really putting cement in a metastatic lesion, whether it's alone or after radiofrequency ablation or balloon kyphoplasty, it's used if it's a weight-bearing bone. So spine, pelvis lesions, that's where you're going to find the benefit from cement. And I think it's that cement that really get more than the ablation that gives it that stability that takes that pain away. I'll give a case example of a pretty dramatic response. So gets the evidence of the 1A for strongly considering patients with symptomatic vertebral compression fractures from spinal mets, but really any lesions on the spine, I found it very helpful. But that's specifically where that evidence is for. So I saw a question, if the patient, okay, actually that was an old question. If patient does well with a pump for serratus block, will this be a site for ablation? Yes, going back to Ryan's question before that block, I would say it's more of an intercostal ablation they probably could benefit from, is what I call it, rather than a serratus. That's more of an area of a block, but I would refer them to an interventional team for an ablation for someone who responded well and still has pain. To go back to your, that question. All right, so going back to these spine lesions, or like bony lesions and pain, here's a case. So we have a 67-year-old female with newly diagnosed parotid gland adenocarcinoma, metastatic disease of the vertebral spine, and pathologic sacral fractures as well. She was limited to the prone position with severe piercing pain to her back and legs despite escalation of medication. So just poor quality of life, literally laying face down in her bed here in the hospital. Her spouse was like really reading up on options. He's like, we're thinking about cordotomy. I'm like, whoa, all right, we got a lot of work to do. We got to figure this out if they're thinking about cordotomy and at that point. So she ended up getting an L5 radiofrequency ablation kyphoplasty in a bilateral sacral ALF where she had these fractures, another ablation and cementoplasty. And all I'd seen her is face down, prone. I've rarely seen her face at all. And the next day she was sitting on the edge of her bed smiling. I was like, wow, so exciting. And then the next day she was walking. So just such dramatic improvement in pain control. And just some images from the tumor destruction, showing images of the balloon inflating to allow room for the cement. And then they pull the contrast to make sure they're in the right spot. I just love the dramatic results here. She had some insufficiency fractures followed by ablation and then cement. She's walking. So, I mean, just such a great improvement in her quality of life. She was able to stand up, walk around, and enjoy the rest of the time. She had, which was then on hospice, but she was able to enjoy those final days, weeks she had. Just a tiny bit about lumbar pain, because we often see our patients, whether this is related to cancer or not, you'll have your patient with cancer-related pain and their degenerative disc disease pain. And you're sort of managing both. Epidural steroid injections are pretty commonly used. This is a common referral to interventional radiology that we do in the hospital setting, and it could be outpatient as well, because it's sort of a quick improvement in pain for certain types. So if someone has just debilitating degenerative disc disease that's flared up being in the hospital for whatever reason, or continued pain after vertebroplasty just didn't help. If they have vertebral body fractures that are not amendable to those procedures we just discussed, this could be an option. Some risk of dural punctures, infection, these kind of things. But it's really helpful if there's midline pain or bilateral pain is when I see our interventionalists using this as opposed to a selective nerve root block. I feel like this block is more when someone has radicular pain, that sciatica pain radiating down one side, they do this. If it's sort of midline back, that's where the epidural steroid injection can help. So usually I find that our teams, that it can get them in pretty quickly. It can happen during hospitalization, decreased opioid requirements, and then this may need to be repeated down the road months later. Or sometimes it lasts longer than that. All right, sort of the last section is talking about that central neuraxial blocks and infusions, also known as targeted drug delivery. So this is your epidural, intrathecal types of delivery. So sometimes you think, well, epidural, that's for post-op, delivering babies, all those kind of things. Well, I've had at least two cases that have had tremendous benefit for an epidural. I mean, there's post-op pain, sometimes I recommend it in certain patients who can't tolerate opioids. But I've had two inpatient hospice patients that were in the hospital setting that benefited from an epidural. Both were young, we were trying to maintain cognitive, just being awake and alert. One was waiting for his son to return from college so he could say goodbye, but he had just intractable pain from his intra-abdominal metastatic cancer and was just on escalating drips. And this is something we thought of to try to help decrease his pain and allow him to see his son and talk to his son. And it was so effective, it worked really well. We did another with pancreatic cancer, just intractable pain, side effects to the opioids. Epidural was effective. So then we're like, well, if that's effective, but we only can't do this forever. We then went on to an intrathecal pump after that. So for the epidural, there's less fluid in that epidural space, so it requires a little more volume to be infused. Usually 10% of your daily oral equivalents that's used, but we don't have to calculate that. That's what the anesthesiologist does. And so you can see, you guys are pretty familiar with epidurals. And then different risks here. There's the respiratory depression, retentions. That's something just to be aware of. And oftentimes patients have Foley's, may need Flomax. Orthostatic, hypotension we talked about. Usually try to keep them in less than 7 to 10 days. And oftentimes, sometimes we have patients, again, post-op, this can be very helpful. They have their patient-controlled epidural analgesia. So different from there's the PCA pump. This is like a PCA pump for an epidural. So they'll push a button and get a dose and they're around there in the epidural space. So just for a board's kind of helpfulness, down at the bottom, I have the conversion from what's IV to epidural to intrathecal. So you just keep moving the decimal point over one spot. So 10 milligrams of IV morphine is equivalent to 1 milligram epidural morphine. as 0.1 milligrams of intrathecal morphine. So consider this for acute postoperative pain in comfort care patients that don't tolerate systemic opioids or want to be as alert as possible. And then we'll move on to intrathecal pumps or intrathecal delivery. This is when medications are delivered directly into the CSF. Lower volumes used because we already have a lot of fluid in that space. More commonly used medications are morphine and hydromorphone because they're more hydrophilic than fentanyl is more lipophilic, so it diffuses around a little more and is less predictable. And you really want to keep things concentrated in that intrathecal space so that medications are in close proximity to those nociceptive afferent fibers that and it's opioid delivery right in this dorsal horn of that spinal cord. That way you're limiting that systemic side effects from your opioids, those peripheral opioid receptors, because that leads to our constipation and nausea and other side effects. So that's where that benefit is. You deliver it all there, and the amount is just crazy low, how little is needed in that space overall. And so the catheter tip, the surgeon placing it will determine based on where the pain is, where to place the tip of the catheter. And I have just some examples here of like where they would put it. Usually started with a trial. So there's usually, if you're said, I think I have a patient who'd benefit, you can find some pain clinics are doing this that are run by anesthesiologists, and then our local interventional team also will do a test dose. So they do a test dose, and then if it's effective, and this is outpatient procedure, which is a 50% reduction of pain is considered effective, then, and this is temporary, because it's like giving a bolus of pain medicine, then they would then meet with a neurosurgeon and make sure they have someone who would be able to manage the pump, which is often at couple different pain clinics in our region, which I can always connect someone with if they're interested. And then a neurosurgeon usually places the pump and then start weaning down on the pain medication. So we do not have to wait till they're on 800, 1,000 OMEs. We can start thinking if you have a 200 or more OMEs, chronic refractory pain related to cancer. It could be abdominal, pelvic is more commonly good indicators. Intolerance of systemic therapy. If their life expectancy, one of the criteria is expect to be at least 3 months. Usually the cost benefit is when they have a pump for 7 or more months, there's a definitely cost benefit. Here's a picture of where it's located. And also with that, patients have their own, they can get it placed and they get a patient, PTM patient, like monitor where they can give themselves boluses. Often it's every 2 hours, they can give themselves a percentage of their daily dose in a bolus form. And those are the things that get titrated up or down. But the amount of when a pump is filled, it could last for usually several months before they need it. The other thing to be aware of is spinal cord stimulation. This is delivery of the electrical stimulation to the spinal cord to inhibit that sensation of pain with just goals of increased function, decreased pain control. It can be really effective in neuropathic pain syndromes, especially focal pain. It's better if it's focal. If you're like, I have pain everywhere, this is you can't really do a spinal cord stim because you really need a focused area of neuropathic pain in general is what, again, does the best. Usually when conventional therapies are ineffective. So radicular pain syndromes, CRPS, radiation-induced neuropathy, chemo-induced neuropathy. Show the evidence levels here, 2, 3C for refractory cancer pain or 3C for chemo-induced peripheral neuropathy. And you see that photo here are each electrode here could be, you could adjust settings to have it give different levels of electrical stimulation. But there's a risk of CSF leaks, infection. We had a patient recently, we had this, the trial was great. So you start with a trial, so you don't have to implant everything. If that's successful, then they go to a surgeon. So the trial can be done by a lot of pain specialists, anesthesiology, pain clinics. And if successful, then they get it implanted. Some of those physicians also implant. Sometimes it's implanted by a neurosurgeon, but there could be migration of the leads too, which may have to, we had a patient had to be redone just to get back in the right spot. Okay, here's just an example of a case where it was effective. Metastatic rectal carcinoma. This patient had pain to the ribs, pain to the pelvis groin, ended up having an intercostal block, super effective for the rib pain. Lumbar sympathetic nerve block did not help the left leg pain. So the spinal cord trial was done, 70% relief of pain, then moved forward with implantation and had great success with that. So just an example of when it could be used. So just the last thing here, a little addition for this year's lecture. Just wanted to, these are rare things maybe that we'll be referring for, but just wanted people to be aware if they hear about these things, what they are, and know that when nothing else is working, there's always more we can think about. And these are probably in that rare, definitely not your first line treatment, but know that they're out there. So neurodestructive procedures probably sounds pretty bad. I would probably think of a better name, neurodestructive. But neurosurgeons, neurospine surgeons perform these procedures. So there's some neurospine pain specialists. So these procedures disrupt the pain pathways in the spinal cord to provide relief of intractable cancer pain, usually in patients with that limited life expectancy, maybe 1 or 2 years or less. So there is a chordotomy. Percutaneous chordotomy is a lot safer and less risky than open chordotomy. That's when they, this top picture here, this example, create a radiofrequency lesion in that spinal thalamic tract. When I think of that tract, I think of medical school and all learning all the tracts. And it helps with pain on the contralateral side. Everything swaps around. This is done often when the patient's conscious under fluoro guidance. I'm sure they have some kind of pain control though too. And it's for uncontrolled unilateral nociceptive cancer pain after failure of other options. Oh, installing in this second. And then evidence is 2B for that procedure, so not bad. The punctate midline myelotomy I mentioned when we were talking about that hypogastric block pelvic pain when nothing else is working could be a consideration, meeting with the neurosurgeon to see if this would be something that could help our patient with intractable pain. Something called the DRES or dresotomy procedure. Less evidence for this procedure. It's when there's destruction of the destroys the central portion of the dorsal rootlets and horn for neuropathic pain and a focal limb pain. So those are some of our, oh, there you go, a little extra image there. So those are procedures, take-home points. Consider interventional procedures, could be through interventional teams, anesthesiology, for intractable pain in your palliative patients. Sometimes this helps for hospice patients as well. Be familiar with different blocks in order to be able to make recommendations when placing a referral, or just knowing when to refer. Interventional procedures can provide pain relief, decrease opioid requirements, decrease medication side effects, improve function and quality of life. Just if you're looking for a book, this is a pretty comprehensive book on interventional pain management that includes a lot of different pathways of what to do with different areas of pain, different algorithms. So anyway, you may find it interesting. I'm not going to go through all this, but you'll see it on the slides. Sharing some of the references, and we'll move into any questions for the last 4 minutes we have.
Well, thanks, Gretchen. I always learn a lot from this, even though I've heard it a handful of times now, and always appreciate it. I think it's a great reminder that we underutilize this resource. And my encouragement to the fellows is to make sure that this is somewhere not in your subconsciousness, but on your radar when you've got problematic pain issues. And also to consider this, as you pointed out, it's not always last resort. Sometimes it should be further up the chain in our consideration. There are two things that I had. Well, one was just there was a question in the chart in the chat that if the patient does well with the pump for the serratus block, would this be a site for potential ablation as well?
Yes, and that's the one I tried to address during that. Yes, you can. If that works, then I do an intercostal ablation, refer for that. And that will cover, because the rib, anything rib area, that will cover it. And they can do usually up to the max of 4 levels at a time. But they could go in one point, do 4 levels, and another time and do another 4 levels. So sometimes.
Great. The other question I had, you sort of just in your very last comment, you had just sort of almost parenthetically said, can be used for hospice patients as well. I'm just wondering how often you actually see this in hospice patients, and is the cost consideration a barrier, do you think, from more hospice patients getting these potential very, very helpful procedures?
I think it's a great question. I would say one I would consider definitely early and often is if hip fractures just happen, falls, and always a question of just surgery or not. But I'd say that having a block, fascia iliaca block in the ED is very effective. Or if they get admitted, maybe their GIP admitting till we figure out next steps, maybe even doing a continuous infusion pump into that area. So that's one that's low cost. I would say in general, we're not doing the ganglion blocks, ablations, intrathecal pumps. Those are all trying to get in beforehand. But if your patient has an intrathecal pump, the different reps around here do a great job of teaching hospice nurses how to refill, or just teaching the team so they're comfortable with managing an intrathecal pump. So I personally try to get any procedure done before going on to hospice, because can be a significant cost. But something like I think more common interventional procedures, which we didn't really talk about today, that are not related to pain, such as pleural drains, peritoneal drains, those are probably the more common ones that we're sending people back to get replaced, or paracentesis, those kind of procedures, more than these more complex procedures. But I guess you could consider intercostal blocks ablations, but I think there would be potentially a significant cost. I'm thinking more for that inpatient GIP patient. I think those epidurals, thinking of an epidural if you're in the hospital and have an anesthesiologist, considering things like that.
I had years ago, there was an anesthesiologist in town who was very good about putting in epidurals in home hospice patients and then turning over the management to the hospice medical directors. I think that was a pretty unusual circumstance. And are you familiar with anyone, or have you seen any of that happening in recent years? It was so helpful. I just, my circle of connections is not extended to anesthesiologists in this moment that do those things.
I have not, unfortunately, found someone who would manage outpatient. I was seeing a couple of questions. Can you please tell at what stage in pain management you wish the patient was referred to me? So as a palliative physician, I just hope people are referred early. I love the they're not even having a lot of pain or symptoms yet, but they have an advanced disease, they need support, they're going to have a big surgery. I love the pre-surgical consults. Maybe someone who's going to have a big head and neck surgery. So early and often for the palliative consult, but for interventional, there can always be a discussion in an early referral to talk about options. And do you ever use these for GIP patients with bowel obstruction or perforation? I think that an epidural could be used if it's severe pain. oftentimes we're just starting with opioid infusions, and that seems to be all that's needed. But if you have someone who's like, I really want to stay awake to talk to my family, that's really important to me, then that's when I would consider an epidural to try to take as much pain away as possible. And then you may have to do a low dose opioid infusion on top of that.
Well,
Great question. Any others?
Just curious if you developed a relationship with any of the other pain clinics in town who might be more open to the palliative or hospice patients, like specific clinics more than others, or are you sending them back to the hospital where you have more established relationships with the IR team?
Yeah, we have a lot. Is it okay on this lecture? I know it's recorded and sent out. Can I share, if you guys want, I can share a little bit about the different options locally?
yeah,
right?
go ahead. That's certainly fine.
Sure. We have the Advanced Radiology Services is our interventional team that probably works at a lot of our hospitals here in West Michigan, and can be inpatient in some hospitals if they have them, or outpatient. We have our Corwell House Spine and Pain Clinic that does a lot of procedures. It's more of a comprehensive pain psychologist. They also have, they do spinal cord stimulators. They can implant, do test dose implant and manage. We have Dr. Rush, who's a PM&R doc who manages intrathecal pumps. So he's one of our 2 that are managing. And then a newer Haven Spine and Pain Clinic, I'll put a plug in for them. It's a private pain group run by anesthesiologists, and they're a great clinic for patients that may not meet criteria for your if you have a palliative clinic, they will take those patients. So they do a comprehensive manage medications and do intrathecal test dose and manage intrathecal pumps. They can do spinal cord stimulation. So that's a great resource, Haven Spine and Pain Clinic.
Interesting. And you said they do med management as well?
They do. They'll take over a patient. So often, sometimes I'll use a clinic like our Corwell has their spine and pain clinic. We manage them, but the pain medications they'll manage, the procedures if they need a epidural injection or if they need an intercostal block, spinal cord stimulator, they'll do that part while we continue to manage symptoms and support and all that. But there may be a patient who graduates or someone we see in the hospital who doesn't really meet our criteria for our palliative services that may benefit. For example, we have a patient who had a significant injury, trauma injury, who's going to go to Mary Free Bed, and then everyone's like, what do you do after that? He's on such high opioids. I already talked to Haven Spine Clinic. They're going to see him after Mary Free Bed and help with that wean off of the opioids. So a great resource.
Thanks for that.
Can I ask a quick question, please?
Yeah.
This might have been addressed, but how readily accessible is this in relation to cost? I mean, it's one thing to have the service, but if they're on Medicare and they're on hospice, are y'all able to just get this done, or?
Well, those are 2 different questions, whether on Medicare or on hospice.
Right.
Because if they're on Medicare, and Gretchen, correct me if I'm wrong, but most of these procedures would be covered by Medicare.
Yes.
Yes. Yeah, and I think Medicaid actually covers a lot of them as well. I think that the hospice question, as she alluded to, that's a since the hospice is bearing the cost, that's an individual question for each individual hospice as far as their tolerances for that kind of expense.
So when you're saying that Medicare pays, are you talking about from the lump sum that they give to a hospice service, and they say, yes, you can allocate this, or they
again, I want to be really clear. We're separating a non-hospice patient. Okay, so your normal elderly person that comes in and they're on Medicare A, Medicare B, and they're billing Medicare. You know, the hospital bills Medicare A, the physician bills Medicare B, and everybody's fine for that. Once they're in hospice, it's an entirely different reimbursement model, and it's irrelevant whether they're on Medicare or not, because it's the hospice's determination whether or not they're going to pay that
fixed daily per diem.
Right.
All the needs of the patient out of that, whether or not you're at or in water. So that's the in-house decision. Okay.
All right.
So yeah, it's expensive. Get it done early. Think of it before they go home.
Right.
All right. Thank you, everybody.
Thanks again, Gretchen.